muchas gracias por venir. Mi nombre es Jocelyn Dunstan Escudero y fui la directora de este proyecto Fondecyt que está terminando ahora. Sé lo difícil a veces que es cambiarse de lugar, así que muchas gracias a quienes pudieron venir a la Casa Central y les voy a hablar de recursos lingüísticos y tareas para la evaluación de modelos del lenguaje, bueno, y procesamiento del lenguaje natural en Chile. Fue un proyecto Fondecyt de iniciación que acaba de terminar, entonces necesito agradecer al gobierno de Chile y en particular a Fondecyt por la oportunidad de tener 3 años de financiamiento que realmente cambió la forma en que nosotros hacíamos el trabajo que hacemos. Y gracias también al Instituto Fundamento de los Datos, que está acá presente, y al Centro de Modelamiento Matemático, al que también pertenezco, además de ser académica de la Universidad Católica. Entonces, primero quisiera partir, bueno, debía haber dicho esto antes, viene la charla de Hércules y este es un pequeño resumen antes de la charla para contarle en el fondo por qué estamos acá. Luego de la charla hay un cóctel, entonces esperemos que después podamos conversar más y siéntanse libres de preguntarme cualquier cosa que necesiten saber después de eso. Entonces, en términos de los objetivos y los resultados que fueron obtenidos en este Fondecyt, la primera cosa y la más importante, yo diría, fue crear el primer corpus anotado en Chile y que está liberado a la sociedad científica. Entonces, primero, ¿qué es un corpus anotado y por qué es tan importante? Gracias a la ley de transparencia pudimos conseguir durante el 2018 11 millones de interconsultas, de las cuales 10.000 fueron anotadas. Al tiro digo que es anotar, pero ahí está el mapa de Chile donde se muestran todas las regiones que nos mandaron datos y por eso quisiera agradecer a toda esa gente que respondió a mi solicitud de transparencia. Yo mandé transparencia, o sea, mails a cada servicio de salud en Chile. Entonces, ¿y por qué nos interesaba la lista de espera no GES? Y desde el punto de vista del texto, es porque la sospecha diagnóstica, que quiere decir por qué alguien está esperando por ser atendido en una lista de espera, está en texto libre. Entonces, eso es tanto una fuente de texto para hacer este proyecto, pero también el caso de estudio y la motivación para nosotros para hacer procesamiento del lenguaje natural. Entonces, ¿qué es anotar? Es como un software como el que muestro acá, donde personas con conocimiento clínico seleccionan una palabra, les sale un menú desplegable y tienen que poner si esto es una enfermedad, un hallazgo, una parte del cuerpo, un medicamento. Es más, nosotros tenemos 10 de estas entidades que se llaman como etiquetado. Además hay relaciones, hay negación, si el procedimiento está pendiente, hay varios atributos que puede tener. ¿Okay? Entonces, de nuevo, esta charla es puro agradecimiento. Muchas gracias a todas las personas con conocimiento clínico que trabajaron en estos 2 años de etiquetado. Y esto es así se ve un corpus anotado. Entonces, se fijan, por ejemplo, los primeros 3 o 6 caracteres de esta frase es un montón de información clínica. Está hablando de la gestación, del parto y de los abortos que no tuvo esa persona, por eso está con 0. Además, por ejemplo, hay un diagnóstico que viene de una ecografía que está abreviada. Hay información de imágenes ecogénica, hay una sospecha diagnóstica, ovario con 2 quistes. Hay un montón de información clínica que uno puede enseñarle a los computadores a detectar automáticamente. Y de eso se trata este Fondecyt, de tener primero los recursos lingüísticos, que es el corpus anotado, y luego tener los modelos que a un computador le permiten hacerlo automáticamente. Entonces, este paper es súper importante para nosotros porque obtuvimos Best Paper Award en un workshop clínico de IMNLP, que es una conferencia súper buena en procesamiento del lenguaje natural, y es tan importante porque fue la primera vez que nosotros ganamos un premio con este trabajo. Y eso nos motivó y nos invitó a escribir este paper en ACM, que fue gracias a que ganamos el Best Paper Award, y así siguieron varios papers. Hay, por ejemplo, uno con René, que está en el público. Escribimos también papers en español, tratando de buscar acercar lo que estábamos haciendo también a las personas en el área clínica y que toman decisiones con datos. Eso es el corpus. Ahora viene el modelo de reconocimiento automático, que la idea es que los computadores, como les decía, partan con una frase y puedan saber, por ejemplo, en este caso la frase es pacientes con cáncer de colon, tratar de entender, ¿es paciente algo? No. ¿Es colon? Sí. ¿Podría ser la parte de una enfermedad? Pues es una parte del cuerpo también. Y cáncer es una enfermedad. Entonces lo que hacemos es que este modelo, en realidad son varios modelos, y la frase pasa por cada uno de estos modelos, que con redes neuronales permite leer de izquierda a derecha, y de derecha a izquierda, y hacer un buen clasificador y una buena representación del texto clínico permite poder detectar qué cosa es qué. En este caso, que colon cancer es una enfermedad. Este paper que escribimos junto a Matías y Felipe Bravo, Matías Rojas y Felipe Bravo, fue seleccionado en la conferencia principal en Colin, que es una conferencia de nuevo muy buena en lingüística computacional, y en particular lo que estudió Matías, aparte de la detección de información clave, es lo que se conoce como entidades anidadas, que es cuando una palabra es más de una cosa. Por ejemplo, esto es una abreviación de una enfermedad, o también, por ejemplo, lo que yo decía de colon cáncer, que la palabra colon es tanto una parte del cuerpo como parte de una enfermedad. Eso en computación se llama reconocimiento de entidades anidadas. Es difícil y nosotros mostramos que un modelo simple puede resolverlo súper bien. Además, entre los objetivos de mi Fondecyt estaba el reconocimiento y la codificación de enfermedades, porque una cosa es reconocer que hay una enfermedad, pero algo mucho más potente es poder asignarle un código único de una clasificación internacional. Entonces, esto lo hicimos en términos, por ejemplo, no alcanzan a leer, pero por ejemplo dice nefropatía en estudio, y la gracia es que la nefropatía es una enfermedad. Entonces, un modelo de reconocimiento de entidades nombradas permite detectar que en esa frase está nefropatía y usando un buen buscador enriquecido con conocimiento clínico, uno puede asignarle el código N289, por ejemplo. Este proyecto lo hicimos con el Ministerio de Salud, y ahí están las personas del ministerio, aparte de nuestro equipo, Jorge Pacheco y Paulina Vera, que nos permitió codificar, y por eso el paper se llama Automatic Coding at Scale, porque nos permitió codificar toda la lista de espera abierta y histórica del Ministerio de Salud en nueva especialidad. O sea, 25 millones de casos en la lista histórica. Y a todos le pudimos asignar un código de la Clasificación Internacional de Enfermedades. Y además le aprovecho mandar un saludo a la gente de la FALP, con la que hicimos un proyecto hace más, esto es bien reciente, lo del Ministerio de Salud este año, pero nosotros ya veníamos trabajando en la codificación de enfermedades, en este caso la enfermedad oncológica. Y eso que ven acá, que te permite identificar no solo el tipo de cáncer, sino dónde está alojado, es parte de lo que, si van a esa página oncodata.org, hay varios proyectos de la FALP y en particular está el nuestro. Entonces, el cuarto objetivo y último, no se preocupen, es el uso secundario de datos. Que en el fondo, uso secundario, eso es lo que nos tiene acá hoy día reunido, es cuando uno usa los datos no solamente para la gestión o por razones legales, sino que puede obtener información, por ejemplo, epidemiológica, por ejemplo, de mejora de gestión para la investigación, mucho uso. Entonces, en particular, la lista de espera, como les decía, no es solamente nuestra fuente de texto, sino que nuestro motivo de trabajo, nuestro caso de uso. Entonces, una vez codificada la lista de espera, o sea que cada interconsulta tiene asignado un código CIE único, uno puede varias cosas. Uno, por ejemplo, de identificar cosas que no deberían estar en la lista de espera. Procedimiento, casos que son GES y están las no GES, y esto puede apoyar a la fiscalización que hace la Superintendencia de Salud. Y lo digo tan claramente porque sabemos que la Superintendencia le gustaría usar el modelo. Además, podría ser algo como un mapa de calor de Chile. Imagínense el mapa de Chile y que yo pudiera detectar una enfermedad, psoriasis, y pudiera ver dónde están los focos de psoriasis. Y podría hacer un clic y mirar la mediana del tiempo de espera de la enfermedad en esa región. Es el tipo de cosas que podemos hacer. Y por último, podríamos apoyar el Plan Nacional de Cáncer, mostrando cuánto esperan los pacientes de cáncer y por qué están esperando, por qué diagnóstico específico están esperando. Además, otra cosa que se puede hacer es una estimación de la incidencia de enfermedades, que quiere decir nuevas enfermedades que son sospechadas cada año en Chile. Obviamente, la lista de espera se hace en consultorios y es spam. Eso no quiere decir que es verdad, o sea, que es totalmente comprobada que esa enfermedad que se sospecha es la que de verdad tiene el paciente, pero lo que nosotros mostramos en este paper de psoriasis fue que, de hecho, lo que nosotros vemos mirando la lista de espera en términos de rangos de edad y sexo, y además la distribución en Chile, donde en el sur hay más psoriasis que en el norte, todo eso está de acuerdo a lo que la literatura de la psoriasis dice en el mundo. Así que ese es un caso de uso donde nosotros pudimos comprobar que los datos de lista de espera son ricos. El 75% de la población en Chile está en el sistema público. Entonces usar la lista de espera sirve para muchas cosas. Y por último, y agradeciendo a la H, que es un sponsor en esta charla, en términos de, dado los textos, sacar información clave. En particular con la H estamos trabajando en los relatos de accidente, que uno puede detectar el mecanismo de ese accidente. O sea, que quiere decir como dentro de un relato, que son muchas palabras, uno podría decir, mira, esto le pasó a la persona. Entonces, en particular podemos ver cuánta gente se cae, o sea, cuántas personas hay una detección de una caída en esas personas y cómo el género importa. En este caso, por ejemplo, hay muchas más mujeres que se caen proporcionalmente a la base de datos. Así que agradezco a Pablo Pincheira de la H que está acá y con el cual estamos trabajando. Pero con la H llevamos un montón de cosas que estamos haciendo, modelos del lenguaje, generamos el corpus clínico más grande que está publicado en español, así que estamos muy contentos con esa relación. El equipo, claramente yo soy solo la cara visible y la directora de este proyecto, no podría hacerse sin esta cantidad de personas, y acá solamente están aquellos que o recibieron directamente fondos del Fondecyt o que trabajan en texto clínico. Veo otra gente en mi grupo acá que no está en esa foto simplemente porque no trabaja 100% en texto clínico. En particular hay 4 estudiantes de doctorado y además hay gente de la Facultad de Medicina y de Ingeniería. Así que muchas gracias a ellos. Y en términos de actividades de difusión, porque yo trabajo en lista de espera, es un tema súper sensible y además que recibe mucha atención, he dado un montón de entrevistas y además, bueno, como que el área de inteligencia artificial, ingeniería y salud, a mucha gente le interesa. Así que muchas gracias y en particular tengo un podcast que se llama Ciencia de Datos en Salud. He entrevistado a varias personas que veo sus caritas ahora, así que muchas gracias y cuando lo invite a estar en el podcast ya sepan que es por esto, ¿ya? Así que gracias y gracias de nuevo al Instituto Milenio y Fundamento de los Datos que hace posible tener un podcast. Entonces, a lo que vinimos. Hercules Dalianis, el caballero que está acá, él sabe que yo voy a hablar en español, o sea que estoy hablando en español y ahora vamos a partir con hablar en inglés, pero Hércules, yo lo conocí porque él escribió este libro que se llama Clinical Text Mining, lo escribió el 2018 y está abierto para ser descargado. Entonces esa fue mi primera experiencia. Cuando empecé a trabajar en Clinical Text Mining, bajé el libro, lo imprimí y me encantó y le escribí a Hércules como, oh, hola, leí el libro, me gusta, y Hércules me contestó súper amablemente y por eso además accedió a venir a Chile, así que muchas gracias y es parte del invitado internacional de mis fondos. Entonces Hércules tiene un magíster en ingeniería eléctrica, un doctorado en ciencias de la tecnología por el KTH en Suecia y es profesor titular en la Universidad de Estocolmo. Así que dicho esto, dejo con usted al profesor Hercules Dalianis. Gracias.
Aló. Buenas tardes. Yo sabe poco español también, pero no puede. I can't hold this lecture in Spanish yet. Thank you very much for inviting me to Chile, Jocelyn. I'm very happy about that. And I will talk about, well, you presented me. My background, as Jocelyn said, is electrical engineering. And I finished electrical engineering in 1983 and started to work as an engineer at the hospital repairing medical equipment. And then I saw a course in artificial intelligence in the university, Stockholm University. It's not KTH, it's a university, general university. And I went there to see what artificial intelligence was. And it was okay, nothing especially exciting, but everybody was talking about it. But I stayed there and I studied a little more. I did some machine translation, and then I continued and I said, maybe I should do a PhD in this area. So I started a PhD in text generation, to generate text from like a model, a model from describing telecom things from Ericsson. I finished with that and present my thesis in 1996 in text generation, written in Prolog programming language. And then I went to California for doing my postdoc in 97. And because of the internet was growing a lot, everyone that did text generation stopped doing text generation and started to do text summarization. So I went back to Sweden and did text summarization for Swedish and other languages in around 2000. And then some years later, I was actually contacted by I don't know what it is, like the Region Stockholm, the people that runs all the hospitals, the government hospitals in Stockholm. It's not state-owned, it's like a region. And they said to me, can you summarize a patient record to a discharge summary? Epicris. Is epicris in Espanol? And I said, I don't know, we can try. So I applied for some money. I got money. And then we managed to also start to try to get records. And this was 2007. And actually, well, we didn't know anything about the area. We didn't know about anything about medicine. But I had contact with the doctor, and he said to me, what should we ask for record? Should we ask for heart, or is it gastro, or what should we ask for? Just ask for everything, he said. Okay. So I wrote to this hospital, chief physician, can we have all the data you have? I said, who is that guy who wants all the data? And then we contacted, and we got actually a lot of data. So then we started this 2007. So that's the background. Short. Okay, now I will start talking. And you can please, if you don't understand something, just stop me, ask me. So we can, if it's some questions about the word or something, we can continue. Okay. So I just want to show you this. Stockholm is at the 60th latitude. And you can see the 60th latitude south, it's between South America and Antarctica. So Sweden is actually very, very north compared to actually the most south part of Chile. But because of the Gulf Stream that comes here from the Mexican Gulf, it keeps it warm, so we can live here, and we have a pretty good climate, plus 20 in the summer and -5 in the winter, and we can grow things. So that's why we can survive. Otherwise, it would be very cold in that part. And here's Stockholm University. The university is from 1870, but this is the modern campus built in the 60s. Pretty like 3-4 kilometers from city center, called Frescati campus. And Stockholm University have 73 departments. It have 73,000 students, 2,000 PhD students, 5,500 employees. And we have all type of subjects except you say religion. I think it's religion, and we don't have medicine, we don't have religion, and we don't have engineering. But all other topics we have in the university teach that. It's a lot of distance students as well. So not all of them are on the campus. And our department, the Department of Computer System Science, it's in Kista. It's a suburb north of Stockholm, like 15 kilometers. It's called Silicon Valley of Sweden. We sit in this building now. We have been moving in 3 different locations in Kista. And the department has 200 employees, 15 full professors, 70 researchers, 90 doctoral students, and 5,000 students. And what else can we say about this? And we have 16 undergraduate and master programs running. And we are like pretty big part of the Stockholm University. But it's the funny thing, nobody knows that we are there. So the main campus, like, oh, do we have a computer science department? We didn't know that. Are you in Kista? We don't know about. It's like we're like unknown for everyone. And that's like a little sad, but it's like it is.
45% female.
Yeah. Yeah, it's pretty much. And it's been, I think we had that pretty long time. I mean, even in the beginnings, in the 70s, we had pretty many female that studied this, because it was, we are in the social science department. It maybe also considered that many females doesn't want to do engineering and stuff like that at that time. So maybe they came to us and they like attracted and so on. So that's sad, because I think KTH still have fewer women studying. And I think I studied electrical engineering. I think about 160 students, and I think with 20 men, 20 female students. But still, it's like that, I think, in electrical engineering. The other are probably better, like physics and computer science and other, but still some of them very few. Yes. So I will talk about electronic patient records. I will talk about identification ethics, a little about annotation, a little about machine learning and data science, and then about clinical text mining applications. So text mining is exploration of large text collections find new patterns, facts, or knowledge about the world. I mean, you just search and you try to find things. Sometimes you know what you look for, sometimes you don't know. So it depends on what you want to do. And the content in patient records is in our patient record, because there are, of course, more things, but we have like a serial number that identifies each unique patient. We don't have the social security number, that's removed. We have the gender, we have the age, we have admission, discharge date, we have blood values, laboratory values, code, diagnosis codes, drug codes also. And that's the structured fields. And then we have the unstructured information, the free text. And it's physician notes, nursing narratives, physiotherapists, psychologists, texts. I think there are 7 different professional categories in the records from Karolinska. It's from Karolinska University Hospital, the records also, I should say, one of the biggest university hospitals of Sweden. Lots of different medical specialties. It's like 500 different clinical units. So there are lots of different type of writings and noisy text. Maybe we should say, we don't have psychiatrical notes. And noisy means that they are written with a very specific style from each department, clinical unit. And all of them, well, it's digitized, you know that already. And it's millions of patient records that are produced at every hospital every time. So it's a lot of data that's collected, and usually they don't do so much with it. Karolinska has started to extract data just to get some statistics on how many patients pass through the system, how many people work at this time point, how many nurses, how many doctors. So they do some statistics from the data. They try to find out, you know. But there's lots of things that can be done by using the text. And previously, people mostly looked at the structured data because that was easier for do statistics and machine learning. But now they have been starting to look at the text also, because the texts contain a lot of valuable information written by highly specialized persons. This data we have, we call it Research Infrastructure Health Bank, Swedish Health Record Research Bank at Stockholm University. And it's 2 million patient records, which is equivalent to 18 gigabytes of text. They are from 2007 to 2017, the majority. So 18 gigabytes of text, you can imagine Bibles written on this very thin paper, you know, the Bible paper, very thin paper. So 1 cubic meter of Bibles, that's the text amount we have in this database. And then we have the tabular data as well. And during the years, we had 8 different ethical permissions to use the data for different topics. And also the years have passed, and we had annotated manually 14 different data sets in different areas, from finding clinical entities, named entities, to person names, address, and stuff, but also to find these symptoms, diseases, drug, body parts, adverse drug events, early cancer symptoms, and lots of other things. And this is a very valuable data set that we try to release slowly to use to other hospitals, or also academics can use. We have several PhD theses written on this data set. We have over 100 scientific papers, and hundreds of researchers have been using this data over the years. Both people have come to us from other universities, but we have also released some parts to other universities. And I mean, we can release some parts to anywhere in the world that are academic, so even you can use it. It's Swedish, so it's probably not so useful, but anyway, it's there. And we believe there are not many health banks in the world, maybe 3 or 4 or 5, maybe, at this size. Oops, sorry. Here's one student, Hanna Berg, and my colleague, Aron Henriksson, that is in the server room health bank. It's a special server room with no internet connection, and the servers are there, and it's an encrypted data server. And this room is also only accessed to very few people that have permission to go into this room. And we do most processing we do in this room. as you understand, when we want to program, we have to use our laptops or mobile phone to find the code, because you can't Google it on your this server, you have to do somewhere else. But we can extract some data set and work outside also. A little about the ethics. I heard this new term, as I put it now, we talked about datification, but they say maybe we should say sanitation. You try to clean up the text. Sanitation of sensitive text. The process of removing sensitive information from a text, that is information that may identify persons mentioned in the text, is called sanitation. It's mainly carried out by using named entity recognition. You didn't mention named recognition, yeah. And there are several strategies for this. You can remove the thing you find, you can mask it, or you can substitute it by some pseudo names, locations, or time zones. And here's a text in Swedish that is sensitive, and you see why. This is, of course, not a real text. We have already cleaned it up, so it's not sensitive. But this is things that you should do something with. It's the names of the doctor, its dates, its telephone numbers, and the patient names. Or actually, it's not patient names. Usually, it is relatives to patients visiting the patient. So the patient name is never mentioned in the text usually, but relatives, wives, stuff like that. And you have also a location, the blue thing. And what you should detify is this maybe. I mean, they're not a complete list. We have followed this American, they have something called HIPAA in the United States that they remove 28 categories. We selected these ones that we thought was important. So it's healthcare unit, partial date, full date, first name, last name, location, age, organization, phone number. And then we have also added now email, which is also very important. And we use name entity recognition to identify these. And this we have took this 18 gigabyte and we datified it, used a Swedish clinical model, language model called Swede Klingberg, which is Thomas Vakili there is my PhD student. He built this model from the identified text, and he de-identified the same text. And here you can see the number of entities found in this 18 gigabyte. So it is 14 million last names, 12 million last names, and ages, etc. And you can see the precision recall of the system also. It's around, for names, we are pretty high, 97% precision recall, but we are lower in other areas. So we miss 3%. That means that probably there are several hundred names, first and last names in the text that are still is there sensitive. So we can't clean it up completely yet. And it's described in a paper also about that. Here's the strategies you can do. You have a patient arrives to hospital with broken tibia, anesthetic given by nurse Frederick, paracetamol prescribed by Dr. Modig. So you can see the machine can tag the first and last name, fine. And that means we can maybe replace with a class name, just keep it like that. And the first example is what the physicians want at the hospital or the research. They want us to keep the tags like that. Other is to remove them or mask them, which is a second example, the black. You can remove the whole thing, or you can just remove the names or put black there. Or you can replace them with fake names, what we do here. And we recommend doing the fake name thing, the pseudonymization, because then if you miss some names, imagine we missed Dr. Modig, then I think we have it here in this example. No, we don't have it here. Then it's not visible. I mean, you see just a name and you don't know if that's really a real name or a fake name. So that's a much better strategy. Exactly. And I want to show you a small demo we did. It's built with using the machine learning conditional random fields, and I hope it will start now. I don't know. It's okay. And Aha. I have to do so slow. Where's the aha? Window. Oh no. There's so many. Okay, huh?
Like next to my presentation is the demo.
Oh, there. Yes. You can see here's the address. Sorry. Why is it? Zoom is like hiding everything always. Here you see the address is Hobydid, but you can Google it also. So this is a Swedish datifier built on conditional random fields, trained on data. And it's not directly trained on clinical text. We couldn't put the model on the internet. We felt like pretty unsafe. So we bootstrapped it on some other non-sensitive text, but we used the original model to mark a Swedish news text. News text contains a lot of names and stuff like that. Not so many telephone, but names, and also hospitals and clinical units, if you have enough of them. And here is a text in Swedish. It says 22-year-old patient with TBC, tuberculosis, came to the lung clinic, Karolinska University Hospital, Solna. Patient was in Somalia. This is a fake text, of course. He was followed by his mother, Samir Ahmed, with his telephone number and she had this street, Rodmansgatan 4 at Stockholm. Samir was very old for her son. And the son has a social security number. In Mogadishu, was in Somalia. He swam in the sea and the stingray bit him. And he got a wound, and then he got drugs, flucloxacillin for this, and he had a fever. And now he's okay and he's back. So we press here, deatify, and the machine deatify. You see here it's date, age, and this is actually, it thinks it's organization, but actually it's wrong. It's TBC, so it's wrong tag. The clinic was okay. Place is Solna, place is Somalia, her name, first, last name, etc. Everything. I missed that thing, the social security number, because we have very little social security names to train on in our data set, of course. And so on. And but we can also add some rules. We have some regular expressions, so we run that on top of the machine learning, and then it missed that, of course, that was guilty, but it marked up that thing. And then you can say replace it. You have different strategies here, but we do replace with another word, and we do like this, and suddenly there'll be another hospital, another mother, Siba Wiklund instead of Samir Ahmed, another phone number, another address, etc. We take some places around that. And he didn't swim in Kenya, Somalia, he swam in Kenya. So we just take another African country. And then we take another capital and replace that. Sweden is still Sweden, because Sweden is always there. We don't replace that. So we made some, and then we switched the dates slightly also. But it missed this, for some reason, the regular didn't match that thing. I know that this works also fine for Spanish. We took an article from Tercero here. It's about, I don't know what is about, you know, huh?
What's about climate change?
Language or weather?
Climate change?
Climate change, yeah. Okay. And I use that, and it check this, and why is it so few? Oh, I don't know why. I have to remove the rules. I'll do it again. So the organization is marked up. Antarctica became organization. It's wrong, actually, it's place, but the name's also marked up. So you can use these for Spanish also. Pretty good. Yeah, and then we continue. Where is the slides? Is here. Yeah, and we do like this. Okay, I'll talk about the Swede-Kleinbert language model, clinical model. So this is the one we used for datification. It's built from Swedish Swedish general text called a model called KB-BERT, which is from the National Library of Sweden. It's trained on 18 gigabytes of text from Swedish text from Wikipedia, government documents, some newspapers and books and stuff like that. And then we took the KB-BERT and continued to retrain it on our deified corpora and built a new one that's called Swede-Kleinbert. And then we test this clinical corpora on different downstream tasks, and we obtained 2 to 5% better performance on downstream tasks with this model that was a mixture of clinical data and real text. If we just take a language model built only on clinical text, we didn't get as good performance, and that was interesting. That the Swedish general text, the more data helped a lot to improve the downstream tasks. And this Swede-Kleinbert now is available with permission from the Swedish Authority for Ethical Improvement to share with other academic users. And here's the different downstream tasks we did. One was classification of ICD-10 classification. That means to assign a diagnosis code in some text. One other was to detect protected health information. Clinical entities like symptoms, diagnosis, body parts, and drugs. This is similar. And this is, one is classification, one is near, but this is like similar to clinical entity recognition, but in levels of security of each diagnosis. And also adverse drug event classification. And you can see when we use a pure, maybe this is, no, wait. No, we don't have the real clean model. We don't have that. But you can see the pseudo. This is the Swede-Kleinbert. This one is the one we are releasing. And you can see most of the tasks are better than using, for example, KB-BERT pure with normal Swedish. So it's improved a lot. But also the line, we don't have it here, but the line where we only use clinical text BERT gave lower result of using the mixture of both of them. So this is a very good results. Okay. What I was going to say here. Yeah. So what I was going to say. Yeah, we have said about that. And I think also very important that before hospitals give you text to do research. And what we have noticed now, more and more researchers in medicine ask for more data. 10 years ago, they wanted 100 patient records, and they got that. And usually the hospital tried to deify them manually. Now they ask for thousands of data sets or thousands of 10,000 patients, and they can't do it manually anymore. So they have to use tools. So we recommend the hospital to use this type of datification tools that do automatically work, because it makes it safer when you release the data. But they haven't really in Sweden yet understand that. I think it feels like they don't trust these tools yet. They feel more confident about doing it manually, but it costs a lot, takes a lot of time. And also we know manual datification is probably difficult to do because people get tired when doing the manual datification. And also to do language models safe, you need to remove the things before you build them. That's also very important, like the example we had. And the good thing of using general Swedish and clinical data is that you mix the two languages and language types. In the general Swedish, a lot of names are mentioned, but they are not sensitive. So you mix them with the few we missed, and then it's like pretty safe because we hide a lot of data in that way. Thomas' PhD research have been focused very much on to attack these models to try to extract names. So he had done different ways to try to find names and see if they mentioned a name and a diagnosis together. And he managed to get out some of these, but it's very difficult. Sometimes he fails and sometimes he succeed, but they're many times wrong, also wrong diagnosis to right person. So you can't really say anything about it. So we feel it's pretty safe. And also these BERT models are very difficult to extract data for. They're not very generative. So you need several weeks to process to get out the data. So probably people will not do it. The gain is very little. Yes. And if you look at rule-based tools and machine learning tools, like 10, 15 years ago, everybody was using rule-based tools to do text mining, but we are going to these machine learning tools. And generally, rule-based tools are very high precision but low recall, while machine learning tools are high recall and low precision. And of course, you can imagine also what we do is that we use this, combine these tools. That we have machine learning part, and then we do some rule-based, which is easy, like telephone numbers, social security numbers can be used by, and emails is very easy to catch with rules like regular expressions. And to do some useful work, you need reference standards or gold standards. That's why also we need these annotated data sets, manual annotated data sets to evaluate our results. How good are they? But also good to have for training data. And what we also do when we annotate data, we let two annotators do the same task, so we can see how close they are to each other. If they usually we can say it's 80% F score in annotation between two annotators. That is pretty okay, but if it's lower, it means also the machine will have difficulties identifying this stuff. In machine learning, there we can say it's like two ways. It's either supervised or unsupervised. Supervised is when you have annotated data that you use for training to learn the machine how to behave. Unsupervised is when you just push a lot of data into the system and try to see what you get. And in supervised, it's lots of work because you need to have annotated data. But they are, of course, annotated data you can use already. I don't know about Spanish. You have some of them too, yeah. Yeah. And for unsupervised, of course, they are annotated data. Like, you can have the codes and the drug codes. They are probably there already. Especially the ICD-10 codes are attached to the discharge summary. So you can use that like a pre-annotated example. And I want to show you also how the problems is to run this annotation process. You want to, for example, to annotate symptoms, diagnosis, drugs, and body parts. And that is that you have machine learning to learn the machine to behave like a human. We look at this text. Here's a Swedish text. We have an English translation below. 16-year-old woman with hypertension and angina pectoris, possibly heart attack 2 years ago, admit to hospital with central chest pain without radiation. And if we look at we try to find the symptoms first. The doctor always looks at the symptoms. And we have here chest pain, radiation. Okay, this is symptoms. Okay, it can be something with the heart. And then we mark up diagnosis. Sorry, no, I'm wrong. Negation. The doctor always tries to exclude the symptoms. Does she have chest pain? Does she have fever? Does she have high blood pressure or so? And he has no radiation without radiation. And then the diagnosis will be angina pectoris and hypertension and heart attack. This is what we'll find for words in the text. But there is an uncertainty also here. It's the possible heart attack. So it was a possible heart attack. So it's not sure when they say possible. It's the doctor usually says signs of, or that's probably the word they use here. And then we look at the period of time, 2 years ago. That means they had a heart attack 2 years ago. Probably not very interesting. So diagnosis here is maybe angina pectoris. I don't think it is even, because they have no radiation here outside, just chest pain. So it can be something different. So this is what we need to annotate, and then use a machine to learn this way to behave like this, and then we enter new text, and it will find stuff like that. And there's some challenges in this healthcare. One is to assign ICD-10 diagnosis codes to the epicrizis or discharge summary, and we know that around 20 to 30% of the codes are wrong. It are missing codes in the discharge summary. And therefore, we need a tool for automatic code assignment and also validation. And we have used some tools. We built a tool called EasyICD. We did this in Norway, in my other project in Norway. So here you see a gastro note of a patient that came in with pains in the stomach and did gastroscopy, etc., etc. And then the machine proposes a number of gastro codes, K codes, and these are the same in Spanish as in Swedish, but just the text describes them different. And this is an experiment we're just running now with coders, nurses, and doctors. We let them read the text, and then the machine propose code, and then they choose the codes they think are correct. If they don't feel them correct, they write here, I couldn't find any code, and then they continue. And then we did the same experiment without the help of coding, and see how good they can code it. And then we compare how much time they used for coding with the tool and without the tool. So if the tool helps them, they will be using less time to do the coding, is this idea. So we take time off the coding work to see how useful this is. And we have actually Swedish data used in Norway, because we couldn't get Norwegian data in time for the project. I got a lot of money from Norwegian government to do this work, but the Norwegian hospital, which I'm actually hired at the hospital in Tromsø in North Norway, my group people, we are working there. It took 2 years for them to give us the data, so I have to use Swedish data that I was allowed to share with them. So the coders now are both Norwegian nurses and Swedish doctors and Swedish nurses. But Norwegian and Swedish are very close to the languages, so we can use them for doing the work. The coding tradition is different, but the work's the same. Another is healthcare-associated infections. It's when you go to the hospital and you get treated, and then you get the disease while you are at the hospital, in the hospital. And these are typically a urinary tract infection, pneumonia, and sepsis is like very common problems. And usually get them because you're there a long time with a catheter or have some respiratory things, and you get pneumonia. And the hospital management want to know how many people get it. 10% is like the standard, but you want to make this number lower because it's painful for the patient to come back to the hospital. It costs a lot of money to do this. Don't just avoid it, get it. So they want to calculate this, and they want to do it automatically. Today, they monitor it by manually. They read the patient record and try to find these adverse drugs, these adverse events. And this is typical infection doctor work to do this. Usually the other specialties know that the patient will get this, but they're not so interested in to study this. They just fix them, give them some more antibiotic, and then send them home. But they want to have statistics on this. So we have built a tool for doing this, and this is very popular area I think probably you have it in Spanish too, tools for doing this automatically. Another is automatic detection of adverse drug events. Because 4% of all admitted patients are admitted to the hospital because they get adverse drug events. They get some symptoms that make them feel bad. And this is very interesting because we have a data set with patient records that contain real patients that are ill. Most drug tests is done on young men and no women. And the patients are usually both men and women. They're old, they're sick, they're weak, so they get more adverse drug events in reality. So it's more and more interesting to study these adverse drug events in real data. And also, we have done mining events preceding a cancer diagnosis. That means that it will be so cool to find very early symptoms of cancer before the cancer comes up. And you can do that by studying primary care records, especially for cervical cancer, we develop pretty slow. Try to catch them there. If you don't catch them with the screening procedure, you can catch them in the early symptoms. And here we have a real patient record, and it's pre-annotated. That means that we have trained it on, we have annotated it with the data we annotated before for symptoms, diagnosis, body parts, and drugs. And it was marked up. And this word that is not in English, I've translated to English, others you already understand. And you can see it's a body part, vulva, vagina. It is also easy bleeding mucous membranes, but not tumor suspicious. And then the annotator get this text and it has to fix the text, so get a better data set. So he or she goes in and correct them with this tool. This is a tool called, what was it called now? BRAT. I think the tool is called BRAT. That does annotation. So we changed here, for example, not tumor suspicious. We added a negation here because the machine couldn't find the negations. We didn't have that. We added also easy bleeding. No, sorry, it was something else we added. But you can see we added some things here. Another here also, vaginas pluralis, and some others. So we corrected it. So the pre-annotation helps the coder to just annotate. And then we had the data and we can run it again in the real machine learning subset. And what we did is what we found. And you can see here are the very frequent symptoms, findings and symptoms and diseases. I translated them to English: cervical cancer, trouble, nausea, feels well, pain, tumor, pain, fever, cancer. These are very common. But then you have negated ones: trouble, fever with negation, no fever, very common, no bleeding, no pain, no signs of infections. It's not signs of it, no signs of infection. And this is the one with the highest frequency. So you see a lot of stuff is actually negated. You can remove them because the doctor always, when he writes the patient record, he excludes stuff. This is also very cool. This was in Norway, the cancer registry of Norway, Kreftregistret. Norway is 5 million people, and it's half of Sweden. And they have one cancer registry in Oslo, in the capital, where they collect all the pathology report. A pathology report is something what you do. If you have cancer, you go to the cancer doctor, oncologist. They take samples from your body, from what you have, you know, the lung or the breast and so on. And they put in the sample, and then they send it to a special doctor, pathologist that reads this sample in a microscope and try to find out what it is. Is it serious or not? And then he sends that back to the oncologist, and she starts to treat the patient, give them, you know, chemotherapy or radiation, or what do they do? Because that they fix it quickly, and they want answers fast. But then the cancer registry records this to see the statistics. And in Norway, they have done it from, I think, end of 50s, beginning of 60s. They have recorded for many, many years. And usually you have these 5 years. You say if a patient survives 5 years, it's very good. You know, it's pretty good statistics. That means that you have cancer. They do this test every year, and they want to see how this cancer develops. So they get 180,000 reports yearly to this place. And you can see the reports here in the paper form, written in Norwegian, 2 different dialects. Sometimes they use a Latin also, some of very, very much Latin words. Here's the boss of this cancer registry, and here's my student, Rebecca, that was there. And here's one of the coders, so 25 coders, Kerstin. She sits here with the computer reading a pathology report, and she has different books and papers and experts, and she take that and enter it to the database for the registry, cancer registry. And they were so happy when we came there. They want to know when the program will be fixed for them so they don't have to do this work anymore. And here you see a Norwegian cancer pathology report. It's very well written, describing this is a breast mama, grade 3, tumor diameter 50 millimeter, and they write different codes here. And they mean different things, so it's not very obvious what they mean with this PGR and COE67, hotspot, 23% positive cells, blah, 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 etc. And then it has to put in this form, which is like a database describing it. And we can see it here in English, same thing. So what Rebecca did was it took this data and actually didn't use machine learning. We wanted to use machine learning for this, but she didn't use because it was not possible. So she actually wrote some rule-based system to make this happen, to put them in the correct thing. And that means also different tables to translate this to the right format. It's not, you can't just take the number and put it, you have to go through a table or some thing. And I don't know how it's going with this. Hopefully they have continued the work and they hired people to do this automatically. And of course, as I say, it doesn't have to be perfect. It's a lot of data just to be put there. And probably also the coders miss a lot of things when they code. But now it has been something come digital pathology. I don't know if you heard about it, probably some of you. That means that the whole process from the sample to the diagnosis and register in one shot. That means that you have these images. It's just the later years that these images that are pathology samples are made digital and can be sent to other places in the world. So they can be studied in India or Australia in the night. And then in the day they come back and be the report is sent back to the doctor. So like the radiology happens now in the world, that I guess the Chilean radiologist sends examples to other part of the world in the night, so they in the day can fix and report back. So you get like the save time, you know. But what you can do also now is that these samples can be analyzed automatically by computer. So you don't even have to have a pathologist doing the work. You can make a machine automatically read this sample and say what level it is. It will probably not even need to do the pathology work or even the coding in the future. Another area which is used now, it's automatic radiology reports. So a large amount of radiology reports in one domain is usually manually described in radiology report, a diagnosis. And then you can train on the image content and train on the text at the same time, and then let the machine, by looking at the image, say what diagnosis the patient have. And then you can actually even, generate a radiology report. And here's an example from 2017 on a paper. And this is a data set that is open that you can use. So here's the radiologist's text about this piece of lungs. He wrote, no active disease, the heart and lungs have in the interval, but lungs are clear and unexpanded, heart and medication normal. And then the machine have different strategies to generate text. And you see some of them are pretty okay here with different strategies. So you can do some automatic giving up from the image, radiology image directly, some sort of diagnosis. So you can see, you can send home the patient from the emergency unit or keep him there to more examination. Here are some other applications in healthcare, and I mentioned all of them before. What you can do is, for example, text simplification of clinical narratives or discharge summaries, and this is valuable when you can read like a patient record. In Sweden, we can log into a place and read our record, and maybe we don't understand what is written, then we can use a tool to automatically translate the difficult terms to normal Swedish. Another thing is to get text input spell checking. That you spell check and grammar check the text entered by the doctors. You can have. We don't have that in Swedish. It's so small language. And another is to finding implants mentioned in patient record before magnetic resonance imaging. And this is very interesting. We had a colleague to me in Linköping, another city in Sweden, has this as a task, and they got a lot of data. So he is a physicist, I think it's called, and he does the magnetic resonance imaging, and he wants to know if the patients have any implants, metal implants, because they can't put them in a magnetic resonance imaging machine because he can get burns and so on. So they scan the patient record and see if there's mention of pacemakers or stuff like that. So they can say, okay, we have this. Don't do it, or think about it when you do that scanning. Yeah. And here's a book. It's from printed 2018. And I can say like this, the good thing with this book is that it's free. That's a good thing. And the other thing is that it took me, I think, 2 years, 1.5 to 2 years to understand somehow what this area is about with codes, SNOMED, ICD-10, ATC. There's so many systems, mesh, a lot of words I didn't know about. And the whole process of treating patients, how do you do it? And I read that, and then I went on a sabbatical. I could sit down 1 year and write this. Here's a chapter. So I start with about the very ancient first records, the Egyptians and the Greeks, the Arabs, the Swedish. So it's like 2,000 years, 3,000 to 3,000 years before Christ, to around 0. The Arabs are around 1,000. The Swedes are about 1,500, 1,600. Little about the Greek and Latin used. It's a mixture of Greek and Latin, and also Greek and Latin with different inflection depending on what language you speak. If it's German, English, Swedish, you change it also. Little about reading and understanding the patient records. Little about using abbreviation acronyms, a lot of acronyms, which, I mean, they can use a lot of things. PAT means patient, can mean pathologist. It can mean anything, depending where you are. Little about negations, also about the speculative language in patient records. But all the coding system, there's so much coding going on, different systems, you need to know what it is. A little about evaluation. So the book is written for both clinical people and computer scientists or linguists. So it's a mixture of, you can read the part as medicine if you don't know about that, or you read the part of natural language processing if you don't know that. It's about different annotation techniques and statistics and stuff like that, and metrics. A little about building blocks. This is probably obsolete, some of these, because now we have BERT, and BERT does a lot of this boring stuff for you, but you need to trim it. But anyway, you need to know what it is. Yeah. A little about different methods. Some of them are still valid in the modern, active learning and stuff like that. A little about the ethics part. And here's this interesting, I think, all these type of applications in clinical text mining, lots of applications where you can do stuff collected from the whole world, from different articles. And a little about the network conference and stuff like that. So this is all. Oh.
¿Pregunta? ¿Puedo traducir si alguien quiere preguntar?
Well, hello. Yeah. Well, thank you, Professor. Thank you in advance for this lecture. And well, it's a big pleasure to having you here in Chile. I read your book and it's insightful, and I like it a lot, and it helped me a lot in my task, in my work as well. So thank you for that. My question is, how do you see the future of clinical text based on the new technology, like, for example, ChatGPT or OpenAI that releasing like multimodal models? How do you see that?
I like this type of questions. It's so easy to answer them. I don't know. This is a difficult question. I don't know. Well, I would say I would say that I think they're very important to be very careful, because you can't just enter things to ChatGPT. They are sensitive data, so we can't use ChatGPT actually directly. We need to somehow use other tools, or tools we can install in our hospitals or in the universities to use it. One other thing we can do, which actually we have a Scandinavian network called Federated Health. We try to set up environment with machine learning models separate and use them on distance, collect information and do things. But they still have to be, of course, de-identified, because we don't want to get hacked. Maybe that is some sort of answer. Yeah.
If I can add, I think then the annotation of a ground truth, like what is the clinical knowledge that you want to identify with ChatGPT, for example, then it gets really important, because otherwise ChatGPT will always give you an answer, but then you need to have like a ground truth to evaluate and to check for different promptings or different models. So I think that the annotation will never die.
No.
Maybe it was too good, that question. Like another one.
Hi, thank you for the talk. Yeah. I have a question, because we are ASH team here, so we have to work with a lot of clinical data.
What did you say? You are
From the ASH.
ASH.
Okay, yeah. You are the
Sorry.
ASH people. Yeah.
We are the ASH people, yes. And we work with a lot of clinical data, and one of the challenges that we are thinking of working in the next year will be in briefing clinical notes for our patients. And you said that you had experience in summarizing clinical notes, and I would like to know what are the main challenges, things that I have to consider, so I could have a good briefing with with everything that must be considered in the summarization.
There's not much done on summarization. Some is done. There's one very good job. It's in the book. Is mentioned as a PhD student called Hans Moen. He did it for Finnish, and he got pretty good results on nurses' narrative summarization. But then I had the student try to do that for Swedish, and we didn't manage to get very good text. And we used actually we generated text, abstractive text, and it becomes so well. So one idea maybe is either we didn't have a good model. We have this Kiwi Bart, or maybe you should use old-fashioned methods like extractive summary. I mean, you extract sentences and try to create a new one from the original. Maybe that's an idea. Or try to find a better generator that really generates good text, because they are. So that's very strange, I think, that we didn't get better results.
Yeah, I will add that that's something that we haven't worked, because I think it's very difficult to kind of ensure that what you summarize really capture the really good, important from the long text. But I have seen a talk in ACL in Toronto about the group in Colombia that had really good results, and they were using it in the clinic. Of course, it's for English. I mean, this project is about language resources and models, because for Spanish, we don't have as near as all the things that are available for English. So I think that it is very important. I think that in English it's a bit more solved, but yeah.
And Colombia had done previously good text summarization work.
Yeah, there's a strong group of that.
You have to send the paper.
Yeah, I will.
Yeah. I will also say, what else will say about summarization? I don't know what I was going to say, but I forgot. I remembered later.
But then, I mean, I'm a big fan of name entity recognition, so I will say that it's good about annotation and having models for name entity recognition, because imagine that there is a disease. You have a long text, and then in the short one, you want to keep the disease. So that's a good way to have good name entity recognition models, is also to check. Exactly.
I mean, one idea is maybe to do like very, very old-fashioned text generation, that you actually have some sort of canned text. So you take from the original record some information and put and then generate some, and then say to doctor, what do you think about this? You can use it or change it slightly. And maybe they will be happy because they do. I've been talking with people about that, and it's like some doctors seems to do cut and paste. They use some phrases directly from the text or from other, even the coding they do cut and paste because this is very similar. I take exactly the same codes because I have them in the patient record system. So yeah, so. So, and then the other doctors say, no, you're not allowed to do cut and paste. This is the wrong way. You have to do it from the beginning, think and write.
I have a question.
Thank you very much for your talk. I'm from the clinical side, so I'm a radiologist, so it's very interesting. So my question is, how easy is for you to get some of these algorithms and tools in your RIS or PAC system? It helps that you are like hired by the hospital, so they will let you get in the system, and because that is a problem for us. So all these systems they don't talk with other, so it's a challenge. So how do you manage that?
They keep me far away from the hospital. It's really true. We are now, we have this Norwegian project we're running. It's a big one with automatic coding. And we're trying to somehow give them, we cooperate with patient record supplier, which are part of the project, and they have access to the systems, but they can't really do it at the hospital. They somehow have to talk with the hospital. So they don't want to install any software that is not approved, in advance and so on. And it's you don't want to test things before you know they're working. So they're very careful for that reason also.
No, I agree, but the way to generate data, in a clinical setting, because when you want to apply something that has been, used somewhere else and you want to apply in your data, it might not work. So I don't think you can, of course, you have to train and validate your model, but working within the system give you much more advantage. And that is like a limitation in many places. So I was wondering for you was easier.
I don't know if they set up, one thing that we could maybe do in the future, we can't use real data. We can't use real patient record. Well, maybe if they are like in our little server room, if we could have, but they would not allow us, I think, to have real patients in the server.
Because the problem for us is, just to finish, is if I want to try something new and I have to log off my PAC system and get another computer to test something, you know what I mean? If it's within the system, is much easier, and I will use it. Otherwise, I will not use it if it will get me 10 more minutes to test something, right?
Or if we could generate a copy of, one thing we could do, which is possible to do, if all the structured data is I think it's very easy to make a copy of the structured data and then generate synthetic data of the structured fields, because then you can probably hide it pretty well. There are algorithms for that, for the structured part. The textual part is more difficult because you need to make texts that are real, but maybe we don't need perfect real text. We just need texts that are, synthetic. If we have that in the system, we can do things, but we need, of course, also users. We need physicians that use this system, and they are not so happy. They are probably very busy. They're very well paid, and they will not work for us for free, So it's the best maybe you have some money you can hire. So hire physicians that can work for you for a while, just to write they can write their thesis maybe or something, and then they can do some experiments. And maybe that's a way. I don't know.
Yeah, but
yeah.
Thanks.
I could add that when I explain how we got the Chilean waiting list corpus that comes from transparency law, people look at me like, did you really got 11 million referrals from sending emails, real referrals? And yeah, it's a magic. It's a magic that comes de-identified from the source, that the 10,000 that we annotated, we checked by 5 people that were no sensitive information in them. So I think we were very lucky. But I agree with Cecilia that every time you want to do something else, to help radiologists to annotate something or whatever, it gets really much more complicated. So in terms of large language models, when you need gigabytes of text, at least like what we have done with ACH is good because they own their data, so you can have it in that institution like Hospital del Trabajador and so on. But usually it's very hard to do those kind of projects.
They are doctors that doesn't want to work as doctors, and they are very valuable. I have two of them. One in Norway, I have a young doctor that want to be a computer scientist, and he's working the project. He knows everything about things. We try to use him, but he try to avoid. Well, we pay him also, so he works with us. And the other one was he had a doctor, a senior blood doctor, a friend of me actually, that I was going to ask if she knew any doctor that could annotate data for me, and he said, I can do it. I'm so tired of my work. I can go now. So actually, she worked for us like 3 or 4 years with half salary. But she was so happy, and we were very happy, and we learned a lot from her. I mean, she had been working like a blood doctor for like 30 years. She know everything. She went back to work because she needed better pension. She had to work like 10 years before she's retired. So, but try to see if you can see people that like tired of the work and try to get them, and use them in your project and install. The software is easy to install, I guess.
Or young physicians, or people that want to do PhD, or people that like to publish.
Yeah, exactly. They also. We had also infection doctor that was being helped with this sepsis thing. It was fun because we were going to meet. There was a young doctor. He wrote his thesis, and we were waiting for him. He didn't come. He was like very late. And my assistant was why is he not in time? And then he came late, and he said, yeah, I've been working all night in the clinic. And then he came directly to us and continued work. I was like, he's saving lives, and then he comes to us. So you shouldn't complain about doing things. We were so happy about him.
Hi, Hercules.
Hi.
Thank you for the talk. I hope you had a good time here in Chile, especially if you like the pastel de choclo and the mote con huesillo and the sopaipillas we made for you the other day.
Yeah.
And I have a really simple question about your book. I would like to know if there is a plan for a second edition of it.
I don't know. Maybe I should have one. Okay. Well, I will try to. Maybe I should. Good idea. I was so lucky because I got this funding from the Swedish, what do you call the National Bank? Is it called like that? The one who runs the money system in Sweden. What is it called? The National Bank? Central Bank. I think they had the fund, so I got money from them. They had a lot of money. Maybe I should ask again to write the second. I mean, they're good. Yeah. Thank you.
Thank you.
I will say that apart from the book, there is a key paper from you and Aureline Obol that is about challenges in natural language processing in languages other than English. And we have been thinking also to update that paper because like things that happened in 2018, many have changed in 5 years. Is a question.
Hi, thank you so much for your talk. It was very, very interesting to know about the system too. I have the feeling that this is kind of science fiction for us, not because of the human resources and capability and the technical things, but more about the access to real data. It's really hard in Chile, and we have some data protection laws that are quite strict, and that makes it really hard, especially for research. And also in terms of how you build a model to support the extraction and management of this sort of data. So I was wondering if you have any thoughts or views about how this kind of healthcare data bank you have, it's supported in terms of it's financed in terms of how the model works, who pays for that, how do you support that? Yeah,
it's different projects have been applied for. I have no infrastructure money. I have been applying for a couple of times, but I haven't got that. But this different project that runs it, and we keep it going. I don't know if this was an answer really.
Yeah, so researchers pay for accessing the data. That's what.
But it's difficult to get out data. I got some data 2020 to 21 from the Karolinska University Hospital, but they are difficult to get. And as I described also with Norway, they're extremely tough. And now we have got, I'll just say the Norwegian example, we got 1 million euros, I think. Yeah. And from the Norwegian government, the Norwegian, like the Fondecyt. And I asked for data and I didn't get data. We waited 2 years. We used Swedish. I knew that will happen. So we used Swedish data with permission. Now we have got data. We have identified this it is 30,000 patients, 8 million nodes we identified, and we start using it for doing coding system. And the project is finishing in 3 months, half a year, 5 months. So we want to keep the data. So we need to find funding. So the research unit I work with, they will fund it so we can keep running. But we're going to apply for money so we can extend it and keep the data and run it. And if we're going to since we have identified, we can try to make it like a resource for us and say, yeah, we plan to apply to the Norwegian ethical agency and say, the data is identified, can we use it? And we hopefully say, yes, now it's safe. So it will be like, released outside of the hospital. They can't say, we want it back or something like that.
Is there something like a national healthcare data bank or repository or data warehouse in Sweden?
No, not in Norway, not in Sweden. There's no national. There are cancer registers, but that's another thing. But not textual data or not databases like that. And I noticed the same problem. There are other university hospitals in Sweden that have got money and they try to get data from the same hospital and they don't get data. So they come to me and ask for data and I give them some data to work with. It's very strange. And I don't know why it's like that. They're very careful releasing data. But now there are some new European laws that you have to release. It will maybe start, I think, this summer or next summer. So there maybe will be a pressure that you have to release data in some sort. So maybe that will make it easy. But it feels like it's not so strict in Chile, is it?
Can I ask you about that? Because you got a big, massive, sensitive data but the patient protection law said you can't really use their data for research. That's what the law said. So how do you manage that?
For example, the paper with the Ministry of Health that we annotate 25 million referrals, that was always done at the Department of Statistics, actually by the guy that I'm looking, Felipe Arias. He never left the ministry. And but you could say but very strictly, he couldn't read the thing or he couldn't apply the models. I think that because we don't have we have rules, but we don't have a protocol to apply those rules very strictly. I think that sometimes it goes into the group of the university, how they manage and how they do the things. So far we have been able to work with ACH or with the Ministry of Health, but actually there is a project that we are running and we have Thomas Bakili from Sweden 3 months here in Chile because we want to start doing synthetic text. Because some groups, especially in Europe, they cannot work with real text. So the only thing that they can do is to have a bunch of text once, and then they create models that they can produce text that looks alike. And I think that we are going in that way as well.
I can say that I managed to, except of this Swede Clean Birth database, I managed to ask the Swedish Regional Ethics Agency, what it's called. So I had 120,000 patients that was identified. So that's actually, I can release. If you ask if you ask me for that data, I can give, if you sign some paper, I can give it to you. So that's very unique. I think that they gave us permission to do it. And if you do it, you can always ask for permission and see what happens. And you ask for permission and ask another permission, you can do different. It costs like 200 euros or $200 to do that, but it's not much money, and usually they say yes. most times. I mean, for me, but that's the ethical review board. It's more difficult to get the data from the hospital, even if the ethical review board says yes, doesn't mean that the hospital give you the data. They can be very tricky. So, yeah.
Hi, doctor. Nice to meet you. Thanks for the presentation. What is your opinion about the standard FHIR, this fast healthcare interoperability resource? Sorry for my English.
I don't know much about the FHIR. I know it's used. It was used in Norway when we got the data. It was in FHIR form.
Okay.
But you extract the data from the FHIR. Yeah.
I think we have in Chile a new law that is going to be a lot of that. I think HL7. It's pursuing the entire system to be in FHIR. So
it will be interoperability things between patient record systems, right?
Right.
Yeah. I think I guess they do the same in Sweden and in Norway, but I don't know how far they have reached on that.
Okay.
Yeah, I have a course at the university, the Catholic University, that is called Data Science for Healthcare, and there is always a talk on interoperability because I know how hard it is and about the HL7 or FHIR. Yeah, I know. It is a topic.
Hey, Professor. I had a question that's not totally related to data, as most of your talk was about, but using the data that has already been classified, of course, it is very important to have good classification, that the patient's records are maintained secret. I don't know how do you say it. But besides that, what do you think about doing differential diagnostics and applying diagnostic techniques using machine learning?
On what area exactly?
It could be, for example, if you have a system that can process the un informe, a record for a specific patient, like on time, to generate a diagnostic, like in a emergency situation, for example.
But I think there's things going on in that area. I think I wrote a little about it in the book, about especially emergency unit processing. And I think there was some work on that in Australia about, what was it? I can't really remember now, but it was like when they come in people, they want to see how they should treat them, with what order. And they had done some machine learning in that area, I think. I can't really recall now, but I think there's things going on in that area.
Cool.
It's a lot of this, like who is going to be treated first, and if it's high risk, low risk, etc. And I think also there is something going on with all these, typical heart patients coming in. How serious is it? Is it a heart attack or not? Can we give it a quick, answer on that? I think.
Interesting. Thank you, Professor.
And it probably is more written now, I think.
In the meantime, in case that someone wants to ask a question, I can say that I think we have noticed that privacy is really important. And that's why if I will have add another slide on my presentation, because I said all what we did and not what we are going to do or we are planning. So I think that the identification of sensitive information and the times that we are facing, that is large language models that are so big that we cannot check what's going on. So it's very interesting, that area. And I would like to invite you as well that this Thursday 15 at 3 p.m. in the Domeico room in Universidad de Chile, we are having a workshop only on ethics in artificial intelligence. So, and one of the talks is about privacy in NLP. So you are all invited.
Maybe I can lift some questions. One is what Thomas and I are doing also. It's like the lawyers want to know how good things are, how well deified. I mean, they want to have everything 100%, or sometimes they say, okay. But if you can give them a number, they might get happy, you know. Like, if we build a model and we know that's this level of security, and then they can feel happy and say, okay, you can do this. So that's one thing. You need to give them some numbers or some, you know, things. The other thing we have also done, we have extended our work a little to other areas than healthcare. So we are working with the Social Insurance Agency and the Work Employment Agency in Sweden. They have big AI models that is constructed from data that's entered from the work seekers, but also from the companies searching people and CVs. And they build these models, and then they're used for the work seeker to find, or they use it internally. But since these models are extremely big and it contains a lot of information and also very sensitive information, they don't feel very comfortable about it. So they want now us to de-identify. We applied money for doing it, so we hope we get it. We don't know. But if we get it, we're going to de-identify these data sets, and so they can use it for their AI models and feel safe about it. So both in the social security and in the work unemployment thing. So maybe that can also be another way to expand your work, not only on healthcare.
Yeah.
Yes.
Any other question? Seems that no. And now we have a cocktail outside, and anyway, we will be there, so you can reach us. So thanks very, very much for being here.
Thank you.